Good afternoon, everyone. On behalf of AFRH, I would like to welcome everyone to our exciting AFRH bi-weekly webinar series, which is dedicated to exploring the fascinating and critical field of reproduction. My name is Inikwe Uja Samuel. I'm a research embryologist, and I'm honored to serve as your moderator throughout this enlightening session. So, as we all know, this series brings together experts, researchers, clinicians, to discuss the latest advancements, challenges, and innovations in assisted reproductive science and healthcare, from talking about fertility preservation, and of course, to reproductive rights and public health implications, which are topics that matter not only to the science world, but to all individuals and families around the world. Before today's presentation, I would like to run through some of our housekeeping rules. And the AFRH is now concluded. Kindly check your emails, for your certificates and complete the feedback form as requested. Kindly follow AFRH on all our social media handle displayed on the screen. Okay, so for today's session, we'll be focusing on updates on adjuvant supplements and therapy, and we have a distinguished expert joining us in the person of Dr. Moses Fache. Before he takes the floor, I would like to give an abridged presentation of his profile. Dr. Moses Fache is a consultant gynecologist and obstetrician, is a fertility expert, and a distinguished healthcare leader with over 15 years of experience in women's health. As the CEO and medical director of ProCare Hospital Abuja, Dr. Fache provides strategic direction and oversees clinical operations and ensures the highest standards of care in modern facility, renowned for its excellence in cases like assisted reproductive techniques, which includes IVF, ICSI, and of course, minimally invasive gynecological surgery, talking about laparoscopy and hysteroscopy, laser applications in gynecology, comprehensive maternal and child health care, advanced gynecological surgery and reproductive medicine. Dr. Fache combines clinical expertise with strong managerial acumen. His leadership has positioned ProCare Hospital as one of Nigeria's foremost fertility and gynecology centers, achieving recognitions such as ISO 9001:2015 certifications for quality management. And of course, it's a big honor for us to have him here do this presentation today. Can we please give our best or favorite emojis to him? Over to you, Dr. Fache. The floor is yours.
Yeah, good. Thank you, Inipi, for that introduction. Good evening, senior colleagues and colleagues. I will be anchoring this presentation, and I'll go straight to share my slide. We're discussing updates on adjuvant supplements and add-on therapies in IVF. I would start with this opening story of Mrs. X. Mrs. X is a 29-year-old woman married for 11 months. She lived in Nigeria while her husband lived in the UK, visiting every 6 months. Believing distance could delay their conception, they opted for IVF in a high-profile hospital without prior fertility evaluation because there were no fertility concerns. Her husband, on evaluation, was found to have mild oligospermia, about 12 million per mil, and they were offered sperm DNA fragmentation, which turned out to be normal. The wife, following initial screening, was offered screening hysteroscopy with endometrial scratch. There was no video for review, and standard gonadotropin stimulation with premium brands of gonadotropin. 6 oocytes were retrieved, and they went on to have PICSI instead of ICSI. And 4 oocytes fertilized, and they had an unplanned day 3 transfer with embryo glue. There was no implantation. Second cycle was canceled due to poor ovarian response. And having had 2 very expensive high-tech cycles, she decided to seek care in another clinic. However, she was convinced that these add-ons indicated sophistication, which was one of the reasons she chose the hospital in the first instance, and also inferred from the second hospital if they offer those add-ons which are highlighted in green. So the presentation outline will take the form of introduction, what add-ons are, the role of regulatory and professional bodies, overview, and then take-home messages, conclusion. So the objective will be to define what constitutes an add-on therapy in IVF, critically appraise the current scientific evidence, understand international guidelines, reflect on local practices, formulate patient-centered recommendations. Add-ons are optional, non-essential treatments, technologies, or procedures offered alongside standard IVF or IUI cycles, often at a considerable expense to patients, and these may not be supported by evidence. Updates are critical due to rapid emergence of new interventions, marketing pressures, and patient demands. So why are we discussing add-ons in IVF? There are proliferation of these add-ons, which are increasing number of interventions marketed as ways to improve IVF success without significant evidence to back them up, rising patients' demand and expectation, which these are driven by hope, social media, and commercial messaging. Inconsistent definition and practices. There are variations between what the various regulatory bodies, regional bodies believe their view of add-ons. Evidence gap and scientific uncertainty. Few add-ons are backed by robust trial data, as you would get to see going on in the presentation. Of course, regulatory and ethical imperative, emphasis on transparency and responsible innovation. Of course, HFEA, ESHRE, ASRM, and of course their AFRH. Impact on cost, trust, and clinical outcomes. Risk of inflated cost and diminished trust. So briefly, to talk on the role of the regulatory and professional bodies, most of them have limited power over the introduction of treatment add-ons. HFEA, for instance, like some of the other bodies, have powers relating to information that clinics must provide to patients so that they can make an informed choice. In this regard, it's important to know that HFEA does not have the power to determine which add-on comes into IVF, as it were, because it's outside the remit of its powers, the act that establishes it, which is just to mainly to deal with what happens to the gametes outside of the body. But they have the power to compel clinics to provide patients with information so that they can make an informed choice. Others rely mostly on providing guidelines to practitioners, such as ESHRE, ESHRE's good practice recommendation. So I'm going to focus very much on HFEA, which is apparently the first regulatory body in the world to have come out with something to regulate add-ons. So in 2015, they had this traffic light rating, which was just red, amber, green, just exactly like what you see in the traffic light. And these were based on, add-ons were meant to be judged using this rating. Only high quality randomized control trials expected to be used. Increase in the chance of having a baby for most patients having fertility treatment. And then, of course, it consisted of 3 colors, green, amber. Green means the add-on, at least there have been 1 or more randomized control trials that shows that the add-on increased the chance of having a baby. Amber is just like neither here nor there. And then, of course, red means that there may be safety concerns regarding the use of the add-on. And of course, like I said, this traffic light system was mainly aimed at patients, since that's they have so much control over at least let patients see what they are getting so they can make informed choice. In 2023, October 2023, 19th of October, actually, just approximately 2 years ago, exactly 2 years ago, the HFEA and other 8 professional bodies have repeated their commitment to the responsible use of treatment add-on in IVF. And of course, they regulate UK, but their regulations, their recommendations can be adopted by other bodies that regulate IVF in various countries. And so that's the picture of the organizations, the professional bodies that came together to reaffirm that commitment. And so the aim is to have a culture of consistency, transparency, and responsible innovation in fertility care. The goal is to promote responsible innovation grounded in evidence, transparency, and safety. The key principle, evidence first. Offer only if more than one high-quality randomized control trial shows safety and efficacy for a specific group of patients. Continuous monitoring. Track outcomes and report adverse events, stop if there are safety concerns, and then transparency, provide patients with clear, up-to-date evidence referencing HFEA guidance. Research ethics. Unproven add-ons should be used only in approved research centers. Fair charging. There should be no extra cost for patients who are participating in research. So, and then you should only charge if efficacy is established. And then, of course, disclose conflict. If you have financial interest and other interests, you should discuss that with your patient. There should be sector collaboration, share data, promote adherence, and build collective evidence. So this is the updated rating. You see that, they have moved from the 3 colors, red, amber, green, to 5 colors, and to 5 colors. And you also notice that in the previous red, amber, green, there was no symbols within the boxes. And so people who are colorblind could have this, difficulty. So that's one of the reasons, or the main reason why they have included these symbols in between the cycles, the colored cycles. And you can see green means unbalanced. The finding from high quality evidence shows that this add-on is effective at improving the treatment outcome. I'm not sure if at this moment any of the add-ons, is green. Amber, on balance, it's not clear whether this add-on is effective at improving the treatment outcome. It may be because there is conflicting moderate or high quality evidence. In some studies, add-on has been found to be effective, but in others studies, it has not. The gray, we cannot rate the evidence, the effectiveness of this add-on at improving the treatment outcome, not because there is an insufficient number of publication that can be identified. And then black, of course, on balance, the findings from moderate, high quality evidence show that this add-on has no effect on the treatment outcome. And of course, red, there are potential safety concerns. And so this is an attempt. I must declare that this slide is from Professor Joyce Harper of the University College London, where she had tried to compare the AFRH HFEA recommendation, grading, and that of AFRH. See that HFEA main outcome is live birth rate. That of AFRH is based on efficacy and safety. And so you see, recommended, so AFRH classification is recommended, can be considered, currently not recommended for routine clinical use, and then the last session is not recommended at all. And so this is the overview of add-ons. HFEA had given recommendation on 13 add-ons, whereas AFRH has 42 add-on recommendation, and AFRH had classified this on diagnosis and diagnostic test, laboratory test and intervention, clinical management, and then miscellaneous. Of course, this miscellaneous, I included it because I know that Many fertility specialists are cooking up some add-ons in their bedrooms as we're talking, so I decided to put in miscellaneous so that it's an ever-expanding feed, so we won't be surprised if there are many others that were not captured by AFRH. And so because we're discussing add-on, I noticed that the slides were plenty, but I felt that, okay, since we're discussing add-ons, I could as well add something. So I've tried to prepare one slide each per add-on that is identified by AFRH. And so you would see, I've also, beneath it, I had put the guideline stand, what AFRH recommends, ASRM, and then HFEA. So I'm not going to take each of them one by one. It's just something when you have the recording, I would expect that you can take your time to go through them at a glance. And then, of course, you can check the references at the end of the day to see what the various bodies recommend. So this is pre-implantation genetic testing for aneuploidy. And then, of course, it's not used selectively, not recommended for routine use for everybody. This is time-lapse incubation, and then proceed assisted hatching, endometrial scratch, endometrial receptivity array testing, hyaluronan enriched transfer media, that's embryo glue, artificial oocyte activation. This is again used in selected cases, especially in cases of previous fertilization failure. PIXI, hyaluronan binding sperm selection. AFRH says there's insufficient evidence for routine use. ASRM, mixed evidence. HFEA, unclear. But of course, if you also have had the previous implantation failure, you may apply PIXI. Shouldn't be first-time application. IMSI, not recommended for routine use. Insufficient evidence, not recommended. So IMSI doesn't seem to be favored by any of the main reproductive governing bodies. MAX, again, limited evidence, not used, should not be routine. Microfluidic sperm selection, same recommendation. Sperm DNA fragmentation testing, of course, consider in selected cases, again, not first-timer where there is no established fertility, male factor infertility. Oxidative stress testing, male antioxidants, elective freeze-all. You see that is indicated for ovarian hyperstimulation syndrome. And then, of course, ASRM says should individualize. Intrauterine HCG infusion before embryo transfer. Again, it's not recommended. There's insufficient evidence at this time to recommend it. Granulocyte colony stimulating factor. So insufficient evidence, trials only. So PRP, endometrial, ovarian, insufficient evidence, research only. HFEA, insufficient evidence. Endometrial microbiome testing, you see the recommendation. Chronic endometritis testing, biopsy, CD138 treatment, investigate when indicated. And of course, targeted use, not universal. Immunotherapies, steroids, intralipids, IVIG. AFRH is not recommended routinely. ASRM insufficient, HFEA not recommended. Teen endometrium rescue, sildenafil, these have not been tested, so there is no evidence at all. And then growth hormone, same recommendation. Androgen priming, CoQ10 mitochondrial targeted supplements. There's insufficient evidence for live birth rate, unclear effectiveness. Myoinositol, melatonin, acupuncture. So like I said, these are my add-on slides since, we are doing an add-on, so it's good to add something. So acupuncture is not recommended for live birth rate, HFEA not recommended. So this again, another slide from Professor Joyce Harper, where she tried to show that AFRH and the HFEA do not entirely agree on some of these add-ons. And again, it just tells you the protein nature of add-ons. And you would also realize in the course, maybe of the presentation after, that some add-ons could be add-on in certain use cases, and then in others, they are recommended. So now we go into the social aspect. So why so many add-ons in IVF? And I've tried to conceive the idea that the interplay of hope, science, and commerce in the pursuit of success is where, so you see that add-ons, this is science, hope, and economics, 3 cycles intersecting where add-ons emerge, where science meets uncertainty. How does a procedure that looks so perfect on paper is so imperfect in reality? If you explain the process of IVF to, an intending couple, they almost want to feel like they're already pregnant. And then in reality, it's difficult to have up to 50% chance of live birth rate, even at this time, having made so much advancement in IVF. So hope meets disappointment. When people have so much hope and they are disappointed and science cannot answer their question, medicine meets the marketplace. So hope and science initially probably gives rise to add-on. So there's that curiosity. And then, of course, economics comes in and people feel like, yes, we can fill in this gap with something that can make us more money. So many a times, practitioners are driven by financial benefit, even though some have genuine interest in helping the patient. So we're going to analyze these concepts one after the other. So science, sorry, just give me 2. So science and the quest for understanding. This cycle captures the intellectual and experimental drivers behind the expansion of IVF add-ons. The scientific factors include the complexity of implantation biology, which makes it difficult to isolate one determinant of success. Small scale and case series show promise and thereby enhancing early adoption. The pressure to innovate encourages translation of bench science to bedside prematurely. Publication bias favors positive findings, amplifying visibility of marginal benefits. Lack of standardization across studies create the illusion of conflicting results, when in truth, the problem is heterogeneity. Outcome: science in IVF often advances faster than consensus, and each new hypothesis leads to a potential add-on justified by biologic plausibility rather than proven efficacy. And I made this quote that in the absence of full understanding, plausible biology often masquerades as evidence. Hope and emotion. This is the patient-clinician dynamics. Hope is the most powerful yet the least measurable force in reproductive medicine. It represents both the emotional needs of patients and the empathetic instincts of clinicians. Patient's perspective. The IVF journey is filled with uncertainty, emotional exhaustion, and financial strain. Each failure deepens the desire to try something new, add something extra, or not miss any possible advantage. Add-ons, even unproven, offer psychological comfort, a way to regain agency in a process that often feels uncontrollable. The clinician perspective, doctors genuinely wish to help, especially after repeated treatment failures. Recommending an add-on can feel compassionate, an attempt to do something rather than say, we don't know. Sometimes, offering an experimental intervention is motivated by empathy, not commerce. When outcomes fail to match effort, the human instinct is to seek something extra to turn uncertainty into action. The economics and the fertility marketplace. While many clinicians are motivated by genuine compassion, the industry itself operates in a highly competitive fee-for-service model, I found that, maybe about 60% of IVF treatment in the UK, where the government is even doing so much in funding IVF, is still privately funded. And so there is a lot of competition, even not to talk of regions where IVF treatment are solely out of pocket. So the market dynamics, clinics differentiate themselves by offering the latest technology or most advanced protocol. Like in the case I started with, the couple, the woman, they were offered a lot of add-ons for their first cycle, which was apparently not for an established infertility, other than the fact that, yes, there was mild oligospermia. Maybe they would have benefited from IUI, for instance. Patients comparing options online perceive more add-on as a sign of sophistication. Pharmaceutical and biotechnology companies actively market adjuncts from antioxidants to immunotherapies and testing panels. The financial models of IVF, high out-of-pocket cost, emotional investment, and lack of guaranteed success makes hope a sellable commodity. When hope becomes a commodity, innovation risks turning into marketing. Then the intersection. At the center of the triangle, where hope, science, and commerce overlap, lies the clinical decision-making zone, the space where add-ons are born and justified. This convergence represents the gray zone of modern IVF, where medicine, psychology, and economics meet. Add-ons arise not from malice or ignorance, but from the complex intersection of compassion, curiosity, and competition, the 3 Cs. Every clinician must navigate this intersection consciously, balancing empathy with evidence, innovation with integrity. Every add-on reflects our collective impatience with imperfection. So I made an attempt to look at the social landscape of add-ons using the Gartner-style hype cycle for IVF add-ons. And then you see that the Gartner graph is a graph that depicts the adoption of a new technology from inception to adoption. And then, so you see that there are 5 stages where you have the innovation trigger. That is when the add-on, in this case, is just introduced, and then there is hype around it. And so it goes on to the peak of inflated expectations, and then it catches the add-on, attracts the attention of the regulatory bodies, and then they begin to provide evidence, information, and then, of course, it drops to the trough of disillusionment. And that's the lowest point there. And then, of course, when it drops, people responsible for these add-ons, the marketing, the information begins to bring more information. So you get into the slope of enlightenment, where you see, so I've tried to position these add-ons at various levels. This is not exact, but just so we see that most of these add-ons are going through these phases. And then finally, you get to the plateau of productivity, which probably, at that time is when we're saying, okay, don't condemn PGT completely, for instance. It might be useful for some group of patients, and then don't use only randomized control trials. There are other high-quality trials that you can use, and it might be beneficial. Instead of seeing most patients, can we look at group of patients? These were the reasons why HFEA had to review its 3 traffic lights to 5 in the most recent guideline. So take-home messages. We should understand that evidence trumps enthusiasm. Not all that glitters is gold. Many add-ons lack proven benefit despite compelling biological rationale. Live birth rate, not surrogate markers, is the true endpoint. But like I said, if freeze-all, for instance, prevents OHSS, then it might be very useful for women who are prone to OHSS. So in that case, it might also end up improving live birth rate, even though there are no studies. There may not be enough studies, randomized controlled trials to ascertain that. Adopt a traffic light mindset: green supported, yellow uncertain, red not recommended. Practice individualized, not indiscriminate medicine. Some adjuncts may help selected patients, not all. Means this would come as part of recommendation. Develop local AFRH guidance, encourage data collection and national consensus, and then, of course, make appropriate recommendation. Ethical obligation. Always ensure patients give informed consent for experimental or low evidence intervention. Let them understand the level of evidence that is available. If it's experimental, let them understand. So tell them about the, if there are no safety data, let them understand it, and then they can make an informed choice. Conclusion and recommendation: adjuvant therapy should be guided by robust scientific evidence, not trends or commercial pressure. Safety and transparency must remain central to all IVF intervention. Practitioners should evaluate efficacy before adoption. The AFRH community should work towards national guidance and data generation on IVF add-ons. And then the ultimate goal: evidence-based, patient-centered, and ethically sound fertility care. These are my key references. I'm sure they will be available to you on the recording. Thank you for your patient listening.
Thank you, Dr. Moses Fache. Can we please give him thumbs up, your best emoji? Thank you. It was highly expository. Thank you, sir. Okay, so indeed, you have enhanced our understanding about the latest developments and application in adjuvant therapy and supplements in the field of ART and reproductive health. So we go into the Q&A session. I would like us to drop our questions and answer in the Q&A box, and it will be attended to. Okay, so we have from Barrister Odinga. She says, good evening. Please, would it be possible to get a copy of this excellent presentation? Thank you. Oh, yes, very well, ma. It is going to be available on the AFRH platform. You can access it after the webinar. The second question here says, what's your take on detoxification for couple, especially the woman before commencing IVF treatment? Doctor?
Well, come again. I didn't get the question.
Mr. Johnson Komolafese is asking, what's your take on detoxification for couple, especially the woman before commencing IVF treatment? I want to believe it's the story you told us first, the first story. So he's asking, what's the detoxification for couples?
The what? I didn't get that word.
Detoxification.
Cost.
No, the detoxification process.
Detoxification.
Yes, for the couple, especially the woman before commencing IVF treatment. What detoxification process should they go through?
Unfortunately, I don't have knowledge about detoxification treatments, so I won't be able to comment on that. If anybody probably has information, I'll be happy for them to, this is a time to phone a friend. Just ask a friend to help answer.
Okay, while we wait for the friend to respond, there's another question from Abubakar. He said, thank you, Dr. Moses Fache, for the detailed and informative presentation. With the available evidence on the role of glutathione on male and female infertility, can genuine glutathione supplements be considered as adds-on?
Thank you. You said Dr. Abubakar, right?
Okay, yes, Dr. Abubakar.
Thank you, Dr. Abubakar. So you see in the classification, I had followed the AFRH classification. We have diagnostic test, clinical test, laboratory, clinical management, and laboratory. And I said I created the miscellaneous group there. Because I think in the evidence that AFRH with 42 recommendation, they didn't talk about glutathione. And so, but they have given principle, even HFEA that talked about 13, add-ons, made it open that anybody who feels that, the list should expand can, if you go to their website, they are open to adding additional add-ons as long as they are supported by high quality, not anecdotal evidence. So if there are large randomized double-blind controlled trials, for instance, that shows that glutathione is effective, of course, it can become part of maybe there will be more expanded studies to see the effect. If you select a group of people and you're using it, it might seem like it's effective, but we all know as scientists that the highest level of evidence is that by randomized controlled trial and systematic reviews. So maybe we need to. Okay. Thank you. Yeah, okay. Go
on. Okay, so for me, I would like to ask, how should clinicians counsel patients about the use of supplements and adjuvant therapies not fully supported by evidence?
First and foremost is, I try to drop, that cycle of science, hope, and economics. Now, sometimes it's the patient themselves, like the particular patient I presented, when she got to the next clinic, she was very interested in knowing whether the clinic offered those same add-ons that she had gotten, even though she didn't get results from that clinic. She wanted to know because she saw that as evidence of sophistication. She didn't see why she couldn't continue the fact that the treatments were quite exorbitant, so they didn't have the money, so she decided to drop down to a clinic that charges lower. But even at that, she wanted to know if they have this add-on. So if we want to be very practical as professionals, we need to be able, there are evidences like these references. You can, in the UK, for instance, they insist that patients should be, who talked about some of these add-ons, should be referred to their website. If you're giving them leaflets, you must refer them to the HEFA website so that they can see for themselves what the evidence, and they are written in simple, plain languages that lay people can understand. So if you have a patient that comes with an add-on, you can talk to them about it. If you offer the add-on, whether you offer it or not, you should be able to tell the patient, this is where this stands. If it's equivocal, like maybe it's on the amber range, you don't know whether the evidence is in support. Because the truth of the matter, we all know that if you look at every innovation, there will be studies in favor and against all of them. So if you pick one study, depending on which divide you want to be, you can use that to convince a patient if it's something you offer. But we want people to be transparent, give both sides of the evidence. This is where it is. And then the patients can make their decision whether they want to use it or not. So sometimes even the pressure from the patient, they will come to you and say, yes, I have been told this doesn't really work, but I just want to give it a try. Because at this point, I am hopeless. If I don't do anything, I'm going to remain childless. So why not try this? Because I've heard it helps few people. So this is the challenges, counseling and trying to convince somebody who says, I came here because I heard you offer this, and then you say, oh, sorry, it doesn't quite give the result you're thinking. You say, yes, I still want to do it. Okay, so I think it's just something that physicians need to navigate carefully and cautiously.
Thank you, sir, for the response. Okay, we have another question here from Oluwadari Adepetu. He says, a prof in AFRH is of the opinion that heavy metals and some impurities are in the air, and many people are contaminated by these air impurities, leading to infertility. That's what he based the detoxification treatment on. I don't know if you got that, sir.
Yes, that's quite correct. There is what we call hormone disruptors, all these, heavy metals and endocrine disruptors, actually. And there have been a lot of attention on them as well. And so most of the time, it's a preventive measures. You know, there have been campaigns, don't use plastic, don't put them inside microwave and stuff like that. So many campaigns about endocrine disruptors. So I'm not disputing the fact that there could be this issue. What we're saying is, as clinicians and scientists, we know how to organize research questions and do your comparison. You know, there should be collaboration. You can ask other clinics to send patients or maybe tell them how you are doing your detoxification. Let it be something that is widespread. If you're doing it alone in your center, until you provide every randomized controlled trials, if I have results comparable or better than your center, then I may not feel like what you're doing adds any benefit. So nobody is disputing the fact that there are endocrine disruptors in the air, heavy metals, creams, lipsticks, all the things that women especially apply to in their bodies. But the thing is, we need to do studies. You see that HFEA was very strict in their first recommendation, where it was just strictly, they wanted something, anyone that's going to be green should have had at least one randomized control trial. And as we're talking today, there is none of these add-ons that is ever green. It's just red, it's just amber and red. So you can see that it's difficult. So, because again, there are challenges in doing randomized controlled trials in medicine, especially in situations where there may be some anecdotal evidence that shows benefit. How do you deprive someone? But of course, you would have patients who can't afford that. So maybe you can find a way, there should be a way that people can present their data. Even high quality cohort data can be used. There was cohort studies that established the relationship between smoking and lung cancer, for instance. So, that's why the HFEA have to review their strict red, amber, green classification, and now they've made it 5, so that even some other endpoints apart from live birth rates can be considered. So, but the emphasis is on we must practice evidence-based medicine and try to individualize our patient. Once you bring this evidence and you show studies that confirm that, yes, what you are doing helps, benefits patients, it improves their condition, then all of us will be happy to jump into it.
Okay. Thank you, sir. Thank you, sir. Sir, I would like you to shed light on how supplementation, like supplementation with maybe zinc, selenium, or L-carnitine, how it affects male fertility outcomes in ART.
I do not. We know that they are antioxidant, and some of these conditions are affected by excess oxidative stress, and so there is some evidence, again, not randomized trials, to show that giving antioxidants can improve their condition, but it's not one size fits all. You see that many a times patients take this antioxidant, the same one that another patient took and was successful. Some take it and they have a diminution in their sperm parameters. So again, going away from the fact of let's not use little evidence, because for me, for instance, I have mixed outcomes when you give patients this antioxidant. And what I tell patients is, if I find that your semen is probably poor, I would advise you to freeze some first. Just freeze some, and then we can now start taking some supplements. And then if you get improvement, that's fine. If you don't have, if you go down, because some people have moved from low to zero while they are taking this supplement. So
Exactly.
until we have evidence, unequivocal evidence to show their efficacy, we cannot say unequivocally that they are very beneficial. So, but there are things we all turn up, and as we say, if there is a gap in science, we'll fill it up with whatever comes to our head and makes makes a plausible sense. But the outcome in reality, that's why you can explain IVF to somebody, or you just get egg mixed with sperm, form embryo, transfer it back, and they look at it like a seed and soil. And they know that when farmers plant good seeds, they get a lot of harvest. And so they're already thinking in their mind that they're going to get a baby. And so, I mean, there's that disappointment when they eventually end up not having success after 1, 2, 3 recurrent implantation failure, which is the term that we have used to just cover up that knowledge gap that we're still trying to unravel in the reproductive science arena.
Okay, thank you for your response. Lastly, from me, sir, how does immunotherapy or corticosteroids, the use of this very immunotherapy and corticosteroids, how does it affect implantation success rates so far?
From the evidence that I have presented, none of them, I mean, they are meant to modulate presumed immune causes of implantation failure. So you have steroids, prednisolone, dexamethasone, you have IVIG, you have intralipids. They are generally safe, but there is no high quality studies on them, as it were, that showed live birth rate benefit in unselected reproductive recurrent implantation failure. They are costly, especially IVIG. So most people tend to use intralipid now. And then, of course, monitoring burden. So X-ray not recommended for routine use. ASRM said there's no sufficient evidence. HFEA not recommended at all. It's a red under HFEA classification. So again, like I said, some of these add-ons have some benefits in a few subset of patients. And so the emphasis is to be able to identify those subset of patients and be able to use such therapy for them. If you do advanced testing, I don't know how many centers around us here in Nigeria can do some of those advanced testing to determine that, yes, it's actually immune. The recurrent implantation failure is immune related. Most times it's a presumption. If there are no structural abnormality in the uterus, you have good quality embryo, and then you transfer, the endometrium looks good, Doppler studies are fine, and then the patient fails to implant, then you begin to think, so there are simple testing, antiphospholipid antibody and stuff like that, but the advanced testings are not commonly available, and so most use are presumptive. They are based on presumption. And so, but then, of course, if you have a patient who have all these characteristics and is not implanting, rational sense will make you like, well, let me try this. And some of them have succeeded. Again, we go back to evidence-based and say, okay, has this been subjected to high quality study? Even if we don't have randomized, have we followed up this patient like a form of a cohort study to say, okay, yes, we have seen this effect, and maybe publish? Because it's one thing for people to, if you are doing the right thing, at one point or the other, you'll be able to publish your findings so that other people can see and learn from it. Then it might make other centers to say, okay, let us also try this in our center. Let us do our own study. And before you know it, you're having larger, multi-center studies. Okay, so like the HFEA, if AFRH adopts some of these recommendation and we make it open, because I just see a chart, somebody talked about longevity. I didn't quite see what the other thing there, but again, these are products that are marketed by pharma companies. They have not been subjected, because you can choose if you are selling a product, you see each time pharma companies come to present, they make you feel like their drug is best. until the next one after they present and tell you that theirs is best. So there's constant confusion when you rely on what the pharmaceutical companies are telling you and they are supporting you with studies that they sponsor. If you pay the piper, then you will be able to dictate the tune. So we need to be able to have studies that are not sponsored, if possible, by pharmaceutical companies, so that in reality, we can say, okay, this is what we saw away from what we're told. Thank you.
Thank you very much, Dr. Fache. This is highly expository indeed. On behalf of the AFRH, we appreciate you for your time. We are truly grateful. Okay, so with this, we've come to the end of today's webinar. And before I go, I would like to run through some of the announcements we have. Indeed, this session has been highly insightful, and we appreciate everyone for staying to the very end. In respect to the certificates for the just completed AFRH, kindly check your email for your certificate, and of course, do well by completing the feedback form as requested. The AFRH mobile app, which was launched during the AFRH conference, is now an integral part of our digital ecosystem. So please, we would like everyone to please use this very platform to, enhance our interaction with AFRH. Okay, so our webinar series is a bi-weekly event, and it's open for every second and the fourth Wednesday. Just ensure your calendar is fixed. Your alarm is always ready to remind you that, yes, there's going to be an educative webinar series second and fourth Wednesday of every month. So our next webinar will be on the 5th of November, 2025. We also encourage that you stay connected by following our AFRH on all social media, our official social media platforms as displayed on the screen right now. And of course, thank you for being part of this impactful AFRH webinar series. Together, we will continue to advance knowledge and excellence in fertility care. Thank you, everyone, for joining us. You'll have a great week ahead. Thank you.
Thank you.